All right. Okay, we're going to roll. All right. So it is just a couple of minutes past the hour. So thanks everybody for joining. And it's a great pleasure to invite local talent, right, to give a presentation. We've had lots of people from lots of faraway places, but today we're honored to have a local expert, Dr. Ori Wiesel, talking to us about redefining lung cancer diagnosis and care for minority populations. So even though I'm sure lots of people know Ori, I will just give a very quick rundown of his biography, extol his great virtues and accomplishments. He's an associate professor of surgery at Azrieli, and he's also the director of thoracic and esophageal surgery at Tzafon Medical Center in the Galil. His career has spanned experiences in Europe, in Israel, and the United States, reflecting a consistent commitment to advancing minimally invasive and fluorescence-guided thoracic and foregut surgery. Uri graduated summa cum laude from Semmelweis in Hungary, and then Ori did his general surgery residency at Ichilov, Tel Aviv, and then did a fellowship in Boston in general thoracic, foregut, robotic, and minimally invasive thoracic surgery at Harvard at the Brigham and Women's Hospital. He then went from Boston down to its great baseball rival, New York City, and he spent a few years in Brooklyn at Maimonides Medical Center, and he was there during COVID, and he was the director of a dedicated COVID ICU during the pandemic. Currently, he serves as the chairman of the Israeli Foregut Society. He's a trustee of the SSAT Foundation Board. He's also a section editor for foregut and thoracic surgery in the eminent journal Surgery. And he sits on other multiple editorial boards. And so far, he has authored over 50 peer-reviewed publications. Currently, his research interests include developing a novel biosensor platform for early lung cancer detection in underserved populations. I don't know if that's going to come up in today's talk. Anyway, we're very happy to have him present, and I'll hand over the microphone to Dr. Ori Wiesel.
Hello, thank you very much. Hi, everybody. So first, I would like to thank Dr. Goodman at the Azrieli Faculty of Medicine, obviously Dr. Kakashvili, Dr. Abud, for the opportunity to present here today. And I'm going to present my vision and describe how I'm trying to beat a very endemic and problematic disease, lung cancer. In the region which I'm working at is an underserved area, and with majority of the served by minority population. So hope you enjoy the next 40 or 45 minutes. Obviously, I don't have any relevant disclosure for this talk. So lung cancer is common in minorities and underserved area across the world. I mean, basically every nation, every continent, every country, and every healthcare system across the world are facing an increased prevalence of lung cancer, especially in minorities. These disparities in lung cancer underscore the importance of considering ethnic background and social circumstances in cancer development, risk stratification, and prevention. Thus, addressing these inequities requires targeted public health and interventions, equitable access to healthcare services, and culturally sensitive education and prevention programs, which you must have in order to beat this devastating disease. More than ever, we need leaders who envision healthcare as an equal, modernized system, which I like to use the slogan of AAA, available, accessible, and applicable. You'll see it across my presentation everywhere. So it's a multinational problem, and specifically in minority and underserved populations. I'm sure that all of you are aware that lung cancer is the third most common cancer worldwide, both in male and female. It's the leading cause of lung cancer death death in Israel and across the world. And smoking is the main risk factor for lung cancer. 80% of lung cancer are in smokers, and 80% of smokers have lung cancer. That's a very easy number to remember. But most of you don't aware that the average time to diagnose lung cancer in Israel is 3 to 8 months, which is devastating. 3 to 8 months across the modernized system is a disaster. And up to 40% of patients who were diagnosed with lung cancer in Israel will die before the first treatment, regardless if it's in chemotherapy, radiation therapy, or surgery. 40%, that's an underestimate, but 40% is the number. When I reached Tzafon Medical Center almost 4 years ago, these are the patients which I found. I mean, they were misdiagnosed, and with the presumed diagnosis, one thing, eventually we found something else. Young patients with recurrent pneumonia got antibiotics, as you see in the left side of the screen, had a huge cancer. A 63-year-old male who went for elective inguinal hernia repair, did his x-ray for the anesthesiology, they find a mass in the right upper lobe. 61-year-old man with a disturbing cough. You can see the atelectasis from a tumor obstructing the right upper lobe. And a lady that came with a backache was back and forth orthopedic surgery, primary care, and pain clinics for back pain. Eventually had a tumor invading her back. So those are the main patients which I found in the region which I encountered here. If we take the patient journey in lung cancer these days, it's a very complex system across many disciplines, many tests. And this problem, having those streamlined tests in a parallel direction, if we are available, if a streamlined direction will take 3 to 8 months. Think about 3 to 8 months is a upstage for a patient which is stage 3 to stage 4. Stage 1, stage 2, to which can go to a local or some locally treatment, can be a locally advanced now to get a systematic disease. This is devastating number, which I couldn't accept when I reached here. So my goal was to redefine lung cancer diagnostic care in Israel when I arrived to Tzafon Medical Center in 2022, specifically in a region which is an underserved population. We'll discuss it later, and mainly with minority population. Now, Meir Dagan, which all of you know who is it, he stated a very nice sentence which I used many times in my life. So in order to carry out a mission, one must have 4 things. Define the mission, appoint a leader or commander back in the days, allocate resources, and set a timeline. So this is exactly the fate which I went through to fight lung cancer in the north. So in the next 30 or 35 minutes, I'm going to discuss and share with you my vision and my experience in building a 360 one-stop shop program for lung cancer that include all the aspects of prevention, screening, diagnosis, and treatment, specifically in minorities and underserved population. I'm going to describe in a bit for who was in the call the healthcare in Israel, the system in Israel. I'm going to discuss a little bit about disparities in lung cancers in Israel, specifically in my region, and define the problem as we defined earlier, the problem of lung cancer as an endemic disease in the north of Israel, and how I overcome this problem with a very short access of finance and of resources, but eventually I'll show also the numbers that hopefully will be able to replicate across everywhere we can use that. So a little bit about healthcare system in Israel. Israel is a small country situated in eastern hemisphere or is a part of the Mediterranean. It is the size of New Jersey or 1/10 of UK. We have 10 million registered citizens. Three quarters of them are Jews and 1/5 are Arabs. And the leading cause of death in Israel is cancer. In terms of health expenditure, it's a little bit short than the OECD average, and most of the healthcare system is a public system, and only 1/3 of it is privatized. Now, Israel has a national health insurance law issued by 1994, and it stated that you have a broad basket of treatments, technologies, and medication that are available for all legal residents in Israel. It is stated in 4 It's provided by four health maintenance organizations, or HMOs, or Kupot Cholim. And the emergency services are provided unconditioned to all citizens. And most important is since September 2025, in Israel, we have a screening program for lung cancer when a low-dose CT scan is available for high-risk patients. Now, however, in spite of a very equal and modernized healthcare system where everyone is eligible for treatment, there's a huge variation in this small country. While in the center of Israel, we have three large referral centers and a few general hospitals, and majority of the privatized hospital or privatized system. The other district, the northern district, which I worked at, the southern or the Jerusalem district, has smaller general hospitals, some community hospitals, and most of them are not privatized. So in my region, we have 16% of the Arab population, almost 1.6 million, but this is more than 50% of the Arab minorities in Israel. So the majority of the minority of the Arab population in Israel sits in my region, where there are four main small general hospitals, one large tertiary referral hospital, Rambam, which is located 60 miles from my hospital in my region, and no dedicated lung cancer program for this whole region. Now, 40% of lung cancer in Israel is situated in this region, the northern district of Israel. So I was looking for if one is looking for the disparities, the diversity, the equity, and the inclusion, the DEI in the northern district, we can find shortage of physicians, shortage of expert physicians. We have a lack of medical infrastructure in hospitals, I described earlier. There is no all-in-one services. So there are hospitals where we don't have PET scan, the other hospital have MRI, the other hospital has expert in lung cancer, oncology, but the other hospital don't have surgeons, etc. And there are lack of private system and private insurance. So the majority of patients here in the north of Israel don't have a private insurance that you can streamline the quick test. The residents have limited access to healthcare services. They have to travel to the center to get advanced treatment. There are remote communities, villages, patients are struggling to get medical care and long waiting times. So no wonder that the outliers of the 3 to 8 months are in my region. So if you go back now to lung cancer, so in Israel, we have about 3,000 new cases of lung cancer a year, about 2,000 lung cancer deaths per year. Majority of the patients, like all over the world, are male. And as I told you, the lung cancer mortality is the number one death on lung cancer-related death in Israel. The major risk factor is obviously smoking, and where also in terms of the smokers in Israel, more than 50% of the Arab population smoke. So no wonder this region is heavily polluted with smoking and lung cancer here in the north. And the alarming sign is that Arab youth start earlier. So the smokers started 12 years old. I even found a patient who was bragging that he started to smoke at 6 when he was 6, among one of my patients with lung cancer. So the disparities are across the board. Look at smoking. So as I told you, majority of the major smokers in Israel are Arab males across all ages. However, in women, the majority of the smokers in Israel are Jewish. But we'll see the disparity in lung cancer between Arab and Jews in terms of females. But both male and female in Israel are passive smokers, and this is also because we know that if 80% of the lung cancer are smokers, the 20% are non-smokers, majority of them are passive smokers. And as I told you, the youth, the Arab male, start smoking at a very early age. So this is a very important slide which shows the disparities in lung cancer in Israel. So Arab men are being diagnosed in earlier age compared to a Jewish male. They die earlier, and obviously the survival is shorter compared to the Jewish male. While in female, if you remember, I told you that the Jewish female is smoking more than the Arab female. However, same trend here in like the Arab male. The Arab female are being diagnosed at earlier age compared to a Jewish female, die earlier and survive less. So again, the disparities are favoring the Jews compared to Arabs in terms of mortality in lung cancer in Israel. So diving deeper to the disparities, so we have regional disparities. The number one problem is socioeconomic disparity, cultural disparities, geographic disparity, and the educational disparity. So to be a patient with lung cancer here in the north pertain that it's a stamp. Patients don't want to go to the primary care don't get stamped with a cancer patient. Female don't want to go to a male physician. They're afraid of the symptoms. They're afraid of going to being diagnosed. They're afraid from the tests. So they're not going to be diagnosed earlier, only when they're in advanced stages. The second is the national gaps and disparities. This is in Hebrew. For those who don't read Hebrew, I think everyone read Hebrew. But in an underserved area, people are giving up of advanced care because distance. The healthy versus the poor versus the rich population. There are big disparities between the center of Israel, the urban population versus the outliers, the rural areas. In this periphery, as I told you, the underserved area, people are smoking more and die more from lung cancer. 66% of the oncological patients in the north of Israel are not reaching out for integrative whole oncological treatment, and 60% of them are being referred to oncologists in the center of Israel, have to commute and not to go to treatment near to their houses. This is a disaster, in my opinion. If we take the professional challenges, all of us are medical experts in regardless of the discipline. We know that lung cancer don't have specific odor or sign. It can be mimicking a lot of other diseases. There are very complex regional referral agreements in the HMOs between the Kupot Cholim, the hospitals. It's very difficult to get referral in a timeline when you don't have we have a long waiting list. There are a shortage of experts. They are complicated. As I showed you, there is a long process that you have the patient journey. You have to do a lot of tests. And if you're doing one after the other, waiting for the results, it takes a lot of time. So this whole regional referral and agreement system, Tofes Shvasa, we call it here in Israel, is a very complex, and we have lack of pulmonology, thoracic and oncology experts here in the north. The dedicated test takes time. It takes time. Not every hospital have a dedicated team for lung cancer. To get NGS, the molecular pathology, it's a burden across the whole world, specifically in the small hospitals. And to get to a tumor board is a very complex problem. So if you take it that lung cancer, many patients don't have symptoms. Many patients and physicians are not aware of the system, aware of the symptoms. Those diseases which mimicking other diseases, you can understand why you must have a dedicated team, dedicated experts who is treating lung cancer to diagnose it earlier and not late. So my goal, as I said, was to redefine the system here in the north, and I realized that I have to decrease this awful time for 3 to 8 months and the time to diagnose lung cancer. I have to increase the awareness of physicians and patients to the disease, to the burden of disease, to the lethality of the disease here, and obviously increase the AAA, the accessibility, the availability, the applicability of the diagnosis and the treatment to this region, to keep the patients near the home, and specifically with the disparities, in order to have a regional decrease in lung cancer incidence and prevalence here in the north. So my number one goal was, and which I set up, is to decrease the 3 to 8 months, this patient journey, to 3 to 4 weeks, the time to diagnosis. Then I had to do like a puzzle like a Lego and build a one-stop shop infrastructure, how to take one expertise in one hospital or one HMO and build this puzzle where I had to centralize the treatment around the patient, around a disease, not around the center, not around the hospital. And I did it by finding the best interventional pulmonology system, best oncology, radiotherapy in the region. We built a very dedicated chest radiology, interventional radiology, strong pathology, and build it across a patient, along a patient, around the patient, not around the center. And the most important thing is to find a patient navigator, a patient navigator that will take from the patient and the healthcare proxy the ability to streamline the diseases, which are very difficult even with a local genius, and to find a dedicated patient navigator that will help to streamline this in a rapid diagnosis system center. This is the most important thing which we realize. And this solution brought us to build a regional excellence, regional center for diagnosis near the patient home. And how we did it, we built the 4 pillars, I call it 4 pillars of success. We had to do outreach, build a lung cancer screening program, build a state-of-the-art clinical program, build a strong regional MDT. Now, a multidisciplinary team, it's a very, very crucial tool to plan a disease treatment. And it's a very difficult if you don't have these experts sitting in one office, one room. Okay, so what we did, we identified everyone who treats the patient, and I'll show you how we have had them in the same Zoom, thanks for the COVID, and set them to treat the disease and the patient. And obviously, we built a rapid diagnosis system in order to streamline the treatment. So how we did it? We started with outreach. We did a lot of outreach. We did a ground round at group physician offices, at a regional meeting for physicians and leaders in HMOs. I had a lot of conferences, specifically national meetings, international meetings. I learned the system, how it's been done across the world in an underserved population area. I collaborated with Society of Health Promotion of the Arab community here in the north of Israel as partners to champion this in the Arab community, Arab leaders. I sat in a national boards in the Israeli healthcare system, healthcare ministry, national boards, international committees, the International Association of Lung Cancer study. I'm sitting as a global guideline committee to understand how we can always improve screening and diagnosis, and we had to innovate. Sitting in meetings and speak with the leaders. We went a lot of outreach. We went to municipal town halls, radio programs, TV, media. We went to regional malls and did like happenings where we gave the patients ability to meet experts. We went to the community, went to restaurants, just to teach the region what is lung cancer, what is the problem. Most importantly, we had to build an excellent clinical program. It's not one discipline, not a surgery or a radiology or interventional radiology. We started, we defined as an interventional pulmonology. We bought EBUS, endobronchial ultrasound. We bought navigation system to be able, and we gave it here to the hospital to have a quick referral and diagnosis to the region. This way, patients don't have to go far away to get diagnosis. Then we build up our own NGS. So to get a molecular pathology, which sits in a big hospitals or big labs, you have to send the pathology which you're doing in your own hospital, and it takes until 4 or 5 weeks until you get the result. Obviously, this is a delay. So we realized that every PCR machine since the COVID, every hospital has a PCR machine. So we identify our PCR machine, and we are adjusting the kit. We build an NGS system in 2 years. We had our own NGS system that we are able to diagnose molecular pathology, whole genome sequencing in 1 week, which is excellent. I advise you to do it in your hospital. We got an interventional radiology. We have an expert here that can do it in 3 times a week. We can get lung biopsies. I collaborate with our thoracic oncology experts locally, but also nationally and internationally in meetings that I can get in a consultation within a call, Zoom call. We have a modern thoracic surgery service. We can do every surgery that we want to do. There is no surgery that I cannot do here. Robotic surgery, minimally invasive surgery, maximally invasive surgery, mesothelioma surgery, esophagectomies, lung surgery. Everything we can do here in our center. And this is an excellent service to the patients. We have an excellent teams of experts here also for the postdoc. Now, the regional MDT, as I told you, it's a very important and crucial milestone to build the program, because you have all the experts and all the people that treat the patient. For example, it can be oncologists from one hospital, surgeon in the other hospital, radiation oncologist from a different center, and the primary care who sits in his office. And obviously, everyone is mixed up if you don't have them on the same table. So we established a regional MDT that sits every week, have all the disciplines sitting around the table, and plan the treatment for each patient. We have our pathologists that, with the help of telemedicine and Zoom, can show us the slides. Our own radiologists, which we recruited, the dedicated chest radiologist, that we can do it here and get the expert sitting of every patient. Now, as you know, MDT is not a very easy meeting that everyone is pulling to his own. The surgeons are speaking by taking the patient, want to take the patient for surgery. The oncologist want to take him for the modernized care, medications, immunotherapy, and the radiation oncology thinks that he can do radiation surgery. But this is a very dynamic meeting, which is a very important, because we can treat every patient with the up-to-date treatment. And I'm very proud that we can have this MDT across many hospitals here in the north. And last and not least, which I think is the cornerstone of everything, is the rapid diagnosis center. Okay, you have to build an accessible networks of referrals with radiology networks for local physicians, primary cares, that can reach you to your own mobile. We built up a one-stop shop. We built an app. Okay, for example, you can see our app that the primary care can, with a bot, can reach up to my secretary and is getting prioritized for the rapid diagnosis. There is, for example, a finding in the CAT scan, or the patient has a hemoptysis. He sends a text. It reaches to my patient navigator, and the patient get an appointment the next day. Okay, we have a dedicated apps for that, and it streamline and control the patient journey very easily. We are building an AI system that will be able to mastermind the whole referral system to shorten the gap and shorten the time to get treatment. So this rapid diagnosis system, I'll show the numbers later, was proven to do all these dedicated complex tests in the patient journey that deals with lung cancer in 3 to 4 weeks. Now, if we did it, do you see the video running, Elliot?
Not yet. Oh yeah,
You
now
don't
it's
see it?
yeah, we see
Okay,
it.
so this is like if you hear the orchestra, the violins. So this is our system that basically, as the patient sits in my office, I flag him or her as a rapid diagnosis patients, and we fire the whole system. Okay, so with that, we are streamlining the whole system around the patient. Okay. We are trying to do it in parallel to get the pulmonologist in the same day, the CAT scan, the MRI. If we can do it, obviously we cannot do it for every patient, but we are grouping those tests across the whole system. These are the endobronchial ultrasound, the biopsies which we are doing. And obviously, we are all surgeons. We like to operate, and we are doing the surgery as the last part of the system. But everything is streamlined for the patient, and as you saw, every cornerstone of the system is going by parallel system. We are getting PET scan within 48 to 70 hours when we fire the system, brain MRI within 1 week. We are doing at the same time the navigation bronchoscopy, the EBUS, the chest biopsy, whatever we need. We streamline we flag it to the pathologist for the patient, and we're getting like around 3-4 days turnover time for the regular H&E pathology, and then another 6-7 days for the NGS, for the molecular profiling. We get every week the regional MDT for every experts, and then we decide about the treatment. This takes 3 to 4 weeks, an average. Okay, so this is the system that we built in order to fight the lung cancer. And now, as I mentioned, I promise you the results that I'm not fantasizing. I summarized the 2 years experience that we had in 24-25. The 26 is cooking out. And we can see that between those 2 years, we increased every part of the referral and every part of the system. We have increased in 20% in our interventional pulmonology, more thoracic surgeries, endobronchial ultrasound, surgeries, obviously. There is a decrease in the referral to the outside hospitals to get surgeries, bronchoscopies, endobronchial ultrasound. And our mean, and I was humble here, is 25 days for first encounter. When I got the phone call from the physician, listen, the patient needs to see you. We bring him or her the next day or whenever the patient is available to come. And then this is the first time we shoot the system. And then the next time when we have a treatment decision, when we finalize the workup, it takes 3 to 4 weeks, which is beautiful. And now, for us as a surgical oncologist, and the beauty of that, I think it can be done in every cancer. I'm both a foregut, a general surgeon, and we're dealing with esophageal surgery, gastric surgery, and thoracic surgery. We can do it with every disease, every oncology disease that we have. And I think that's the beauty of it. Lung cancer is the more complex because we have a lot of things we have to do in line. But if we can do it in lung cancer, we can do it if in every surgery, every oncological disease that we have. And what you see here, and it's beautiful because usually the patient everywhere, specifically in underserved population, are being diagnosed in later stages. Let's say we know that almost 3/4 of the patient are being diagnosed in late stage 2, 3, and 4. Now we did a stage shift with those. We have increase in stage 1 patients were down and decrease in stage 3. So this brings us in the end of 2025 that almost 2/3 of our patients are early disease patients that we can treat them, and majority of them, stage 1, we can give them a cure. And this is the beauty of rapid diagnosis and early diagnosis system. So that system works. It's very difficult to maintain that, but the system works for the patient. Further on, if the referral pattern here in the north of Israel in 2022 was the majority of patients in my region were referred for intervention pulmonology to Haifa, to Rambam, to Carmel, to the bigger hospital in the north. Some of them were referred to the centers, the bigger centers in Israel. Some for surgery, obviously for oncology. Most of the patients were the oncological systems were in Haifa. Few of them were here in the systems in Tzafon, in Ziv, in Poria, and in the Emek. Following our establishment of the Division of Thoracic and Esophageal Surgery in late 2022, later on in 2023, we established the interventional pulmonology here in Tzafon Medical Center. And actually, we launched the Rapid Diagnosis Center in January of 2024. We have a significant increase of referral to the local, obviously to the surgery, interventional pulmonology, oncology. We have more patients who are referred for radiation in Ziv, and a patient who referred for treatment in Emek and Poria as well in terms of oncology. Smaller amount of patients have to go out. Every time there will be patients that will go to the center, but there is a decrease of patient migration to the center. Patients don't have to travel far away. Still, some patients are going to the centers in Haifa, but again, more of the patients are being treated here, and I think being treated next to oncology patients who is being treated next to their home, this is an amazing benefit for our patient community. And I think that's the example, that's the beauty, and it's very easy, can be duplicated, reciprocated. So how I see the future in my perspective, we take a triangle, put the patient in the center. So I think we built a system already that works, the clinical excellence of treating lung cancer here, and a rapid diagnosis system that is working. In my end, I would like to, and I'm working with building an academic excellence. I think some of you saw the email, and if not, you will hear that we are launching a lung cancer research center in the Faculty of Medicine, in the Azrieli Faculty of Medicine here in the north. We are launching a lung cancer research center that will master the communication between the clinicians, the academic surgeons that would like to do research in lung cancer, and the lab and the basic science and the PhDs and they would like to do research in lung cancer. We're building this center in the university with the help of Professor Avni and Professor Birati and the whole system in the university. And we will have a opening for that as well, and we'll send up obviously the invitations. And we are building on national leadership. This is the third part of the triangle. We are building a national pilot based on the system for underserved to the the Ministry of Health, and we are getting slowly international accreditation. We are presenting in the multiple meetings and conferences because it works. Not every center is a big urban center. Most of the centers in the world are treating underserved and you know our patient where there is no huge systems, and we hope to duplicate our system, not just national, also internationally. So to conclude, building a lung cancer program, and I'm saying lung cancer program because this is what I established here. But again, I told you it can be every surgical oncology system in an underserved population where it's an endemic problem. So building a lung cancer program in an underserved area has the potential to reduce disparities, as you saw, increase the utilization for the system, increase the adherence for lung cancer diagnosis and treatment, and most important, I think, as a next to patient's home, and provide better care for those who need it the most, obviously. It's not a mission of one person, it's my vision, but I had a vision of my team. We have a whole team that makes this dream to work, and I thank every one of my team, obviously my co-surgeons, my administrators, my colleagues in every discipline which I work at, and with this I will conclude, and I'll be happy to take questions. And thank you very much, obviously, for the opportunity to present. And again, thank you, Elliot.
Great, fantastic. I mean, an amazing lecture and an amazing program. I mean, in what 2.5 years, you've really achieved a huge amount. Any questions or comments from the audience?
Elliot, I want to also congratulate Ori. It's a very impressive. I mean, the style you did it and the numbers, and I think you are on the right way. I have only question. In my knowledge, you are only general surgeon in Israel dealing with lung cancer, yeah? So
Not,
how
I mean,
the thoracic surgeons community accept you when you come from United States, I mean, and start
so,
to deal with
so,
lung
so
cancer?
Thank you, Eli, for the question. It's not quite right because I'm double boarded. So I did my training as a general surgeon, obviously in Tel Aviv Medical Center, mastering foregut surgery, and then I went to the Brigham. I did 3 years of foregut, full foregut program at the thoracic surgery department. And with that, I did cardiac surgery and I completed the full boards in Israel for thoracic surgery. Now, I'm not the only one who did that. We have uh, one more surgeon, general surgeon who deals with that, Guy Pines, if you know, Guy Pines from
Yeah,
Kaplan.
sure.
He's also dealing with both diseases, and we are welcomed as a collaborator. We are fully welcome. The thoracic surgery community treats us as equal. Both of us choose the path of dealing with lung cancer, thoracic surgery, esophageal surgery, which is also it's both disciplines in general surgery and thoracic surgery, and I don't see any problem with that. Even it's for us, it's even better because coming from general surgery and general oncologic residency, which I did, I know a lot of things that thoracic surgeon don't know. For example, in terms of colorectal diseases, gastric cancer, esophageal cancer, the whole immunotherapy that entered the field of breast surgery before breast oncology, before uh, coming into thoracic oncology. So I think the modernized community of surgical oncology in Israel is accepting more, people who are well trained, both in terms of general surgery and thoracic surgery. I know we are three now. We have also James in Sha'arei Tzedek. He is trained in general surgery. He did it thoracic surgery in Montreal. And so we have more surgeons now in Israel, general surgeons who are dealing with thoracic oncology, which I think it's a
Very
great
nice.
benefit because we're also adding to the, trauma surgery, general surgery. We are encouraging to have even to increase in take thoracic surgery and put it as subspecialty or part of the residency of general surgeon should be going into the chest. So I think that can be a well established work for the Israel Surgical Association to collaborate with the Israel Thoracic Surgery Society.
Yeah, absolutely agree with you. I have another question. You mentioned CT scan for screening program for high-risk patients. So who is high-risk patients? Smokers, family history, who else? I mean,
Again, it's Eli, you hit the point. I mean, the classic lung cancer screening program across the world is based on a paper or study, a big study, who was published in the New England Journal of Medicine like 10 years ago. And the population, the whole screening population was based on age, smoking history, okay, and that's basically the screening population. Now we know that there are people which are high risk, like occupational risk. Mesothelioma, for example, is
okay.
a risk from asbestos, but asbestos is also risk for lung cancer. People who work with fumes, people who work with smoke. So, but for a guideline, in terms of guideline for screening, what we defined guideline for screening here in Israel and the health basket included that in September 25 is that patients above age of 60 who smoke more than 20 pack years of cigarettes, who quit smoking in the past 15 years, okay, are eligible out of the pocket, or what we call the סל הבריאות, out of the סל הבריאות, healthcare basket, are eligible to get a referral for lung cancer screening. That it's a difference, it's a low-dose CAT scan, and it's being graded different than the regular CAT scan the radiologist being reading it. So the radiologist expert is getting, he has a different system of reading that, and the different follow-up. If there is a small nodule, there is a different follow-up protocol for that. So this is different. But what I tried and I'm trying to do the Israeli way for that, because the majority of the patients who got lung cancer are not just age of 60, they are earlier, they are smoking more, they are, as I told, they are higher risk for lung cancer, other risks. So I encourage with education for the physicians, for the primary care, to identify those patients and to increase the risk and to work with the Kupat Cholim to send them to a low-dose CAT scan. They are allowed to send a low-dose CAT scan. If the patient is coughing, has dyspnea, has symptoms, earlier symptoms, you don't need to go for the official program for screening. The prerogative of the the healthcare, the primary care, is to send for a CAT scan earlier, not just an X-ray and follow an X-ray, etc., etc., etc. So I think it's also works of public health to increase the awareness, to get the regular scans, not the screening, because the numbers in the world and also in Israel, we just have it almost 1 year now, but the number of patients who are eligible for screening across the world is on, and or especially doing those, is 6 to 8%. So in the US, 8% of patients who are eligible to get free test, not by the insurance company in the US, are going to the scans. So that's a problem. So Elliot just gave me the question earlier. So we are working on getting other tests, for example, urine tests. We here in the Tzafon Medical Center, we are the leaders of a startup here in Israel, an innovating test that we take urine sample for a patient, and we train rats, as you hear me, rats, to sniff the urine test. And with a dedicated machine learning and AI that we trained the rats for 4 months, we got a 92 to 93% sensitivity and positive predictive value for this test for detection of lung cancer. Now, this is just, listen, for a simple urine test, okay? So you don't need to do a CAT scan. So we hope we are going to work, I'm working now with the HMO here to do a pilot study to take this hospital, these regional hospitals in the north of Israel, to try that, to increase the awareness and to increase the referrals for screening CTs with the hope of these simple urine tests. So that's basically the whole logic of that.
Amazing.
Thanks.
Any other questions? Can I ask a question? What are the other centers of let's say thoracic surgery throughout the country done in response to your results? Have they shown an interest? Is this something that can be rolled out in other centers throughout the country? Could this become a national sort of paradigm?
So thanks for the question, Elliot. It's a great question, and I think I mean I didn't invent any rapid diagnosis. I didn't invent early diagnosis. Every center is in Israel and across the world is proud of having a rapid diagnosis system. Now, if you sit in Tel Aviv Medical Center and Sheba, and you have an army of patient navigator, we have army of oncologists that can see you, and you have a huge, you had your huge referral system, and I won't say it's easy, but again, the number speaks for themselves. the time from diagnosis for a patient in Israel with lung cancer is 3 to 8 months. This is a peer-reviewed papers. It's not something that I'm invented. The reports for Israeli Ministry of Health echoes that. So something didn't work, okay? And take what the difference from what happens and what others are doing, what we are doing it here, that we are aiming and centering the system around the patient, okay? And firing the whole system, which is difficult sometimes, even to collaborate all this, imagine Tofes 17 with this HMO and that HMO, and a lot of refusals and approvals, even here. So what I saw two things. I saw, first of all, people got interested of how we did our NGS, how we did the molecular pathology, and I see Professor On here. He's a previous CMO of our OCO of the hospital, who was one of the mastermind of this, getting our molecular pathology here. And I see more and more HMO accepting the fact that you don't need to send the molecular pathology to their own lab. We can do the molecular pathology in our lab. Still, it's not perfect. Still, we are doing our EBAS, the biopsy here, and we get refusal from the HMO to do the molecular pathology here, even though we have the system and quicker than it's in different hospitals. But again, something is starting to move, okay? Other hospitals, regional or community hospitals are trying, and some of them were successful to get this, molecular pathology at their hospital. Again, they are facing the same problem that we have, okay? But still, we are doing it here, okay? Now, if I see a patient which I suspect it's a stage 3 or stage 4 patient, even before getting the final diagnosis, I'm shooting an email to my pathologist and telling, listen, do the sequencing for that test, and our chief of labs and the hospital are helping us to getting the approval post factum. That's something, So no other hospitals trying to do so. So something is moving. Well, like everything in Israel, we are in wartime. It takes time. The other thing is that we saw, following our establishment of rapid diagnosis system and establishing a center here, other regions of even big hospital here in the north try to go to do more outreach, more to the community, trying to cut down the time for diagnosis. Because again, I'm not saying that we are the best, but my interest is the patient interest. So if the patient by the end of the day will get the diagnosis quicker also in Haifa or elsewhere, but will get the treatment around, that's a twofer for everyone, But I think something is moving. I don't think people are copying our things, but it changed for policymakers the way to think, the thing that if we were able to do it here in Tzafon Medical Center, it can be done elsewhere. So I think it's a matter of efficiency, dedication, allocating resources, and it's strategic plan. If Professor On didn't think about that in the earlier days, I wouldn't be here. It wouldn't happen. If I wouldn't get the backup from my administration, it wouldn't happen. Like establishing in the university the next step of having a research center for lung cancer, it won't happen. So I think we envision something like that. And it's not just lung cancer. If someone will decide to do it in pancreatic cancer, because it's an endemic disease here in the north, so Eli can do a pancreatectomy. Here is Dr. Sued, you can do pancreatectomy. You don't need to send the patient elsewhere. If I did here esophagectomy, I'm doing esophagectomy here. Last week I did Ivor Lewis esophagectomy, robotic Ivor Lewis esophagectomy. Doing it here in next to the patient who live in Tiberia, it's a huge. The patient family can come here. It can get the treatment here in the center next to his home to get durvalumab and float for neoadjuvant and adjuvant. the patient can get here. We have excellent ICUs. So I think it can be done. It was easy to demonstrate it in lung cancer because it's very endemic, but we can do it in every surgical oncology discipline. It's a matter of decision, and people who are dedicated who can do that.
What do you think, Ellie? You're not.
I absolutely agree. It's a great talk today and great conversation. Congratulations. Really.
Indeed.
I mean,
All right. Before we wrap up, any last comments? Professor Ahn, you want to comment? Have to.
No, thank you. Thank you for the honor to be part of it.
No, this is wonderful, and it's a great testament to your vision that you've been able to do all of this. Well, Ori, fantastic. Really, really amazing. So, kol hakavod. All right, well, let's wrap it up. Just to let you know that our next talk is going to be next week on Thursday the 9th of July, on a different topic, but I think hopefully should be equally interesting. It's going to be on artificial intelligence and surgery. Obviously, anything with AI is sort of hot ticket at the moment. And the speaker is going to be Dr. Steve Schweitzberg, who is the chairman of surgery at the University of Buffalo in upstate New York. So that should be interesting. So, Ori, thank you very much again. And thank you, everybody.
thanks,
for
everyone.
attending. And it was
Ori,
amazing.
thank you.
Thank you. And everybody
Thank you
should
for the
have a great rest
opportunity.
of
And
the
again,
day.
thanks for all the collaborators who were able to establish that.
Yep. Yashakar.
Thanks.
Bye-bye, everybody.